My name is Ananda and I run Myeloma Patients Europe, which is the umbrella organization for multiple myeloma organizations across Europe. I'm also a lymphoma patient. I was diagnosed with lymphoma when I was 25 years, so you can imagine at that age that this topic is something that is quite close to my heart. I do not have any sponsorship from the company that produces Viagra or any other drugs to treat sexual dysfunction. What I'd like to start talking about is the tremendous evolvement and development of cancer treatment over the past decade. We've really had an increase in survival rates that is absolutely wonderful, but this has brought also with it a bit of a change in preferences, needs and wants from the patient side, from the absolute focus on survival of patients to really a more quality of life perspective when living long or after cancer, what happens then and what are the side effects that patient has to face. And this is what you usually get when you are diagnosed with cancer and you survive and treatment has been successful, you're in remission. People come up to you and say, "You look wonderful. Wow, you're in shape. It's really great to see that everything is back to normal." Well, it's actually not. It's not back to normal. And things usually with cancer patients do not seem as they actually are. So in the background, there are a couple of things that needed to be taken into account. So let's talk about sex. Because nobody, and I was actually, while I was preparing this talk, I was thinking, why the hell did I say yes, And everyone, I met at this Congress came up to me and said, "Wow, Ananda, you're really brave." So this already tells us what it, this implicit thing around sex that we live in society, because nobody wants to talk about this, not even doctors. It's easier for physicians to talk about less embarrassing stuff, and it is true. I have lived that as well as a patient when I was going to my doctor. As clinical goals and outcomes, time pressure to start treatment, that is always the favorite excuse for not talking about embarrassing stuff, survival and effectiveness of treatment, and non-embarrassing, clinically relevant side effects. And often what you're also confronted with as a patient is that false promise that you receive when being diagnosed or going through treatment of the return to normality, which, does never come back in the way it was before. You kind of experience a different normality and you can get used to it, but it would be important to talk about that kind of normality. Patients do also feel very uncomfortable when addressing sexuality in a proactive way, and it is not something that usually happens when you're talking to your clinician, that how are you feeling, Ananda? Oh, well, sex is not really good. It doesn't happen. And then there's the factor of friends and family. A bit of a pressure that comes from them placed on the patient with a bit of an obligation of being grateful for having survived. And that question of, is that really your problem? Is there not more important things you should be worrying about? But, while this is a huge taboo in medicine, and cancer patients, are expected to not talk about it, not feel about it, or not have it as one of the main quality of life indicators in their life and in their relationships. While that happens, you see that, we're bombarded and we experience sex throughout, every day from all sides. And this is also something that, is experienced a bit in a discriminatory way from cancer patients. It's as if that, you know, is a bit a topic from the past. So the important question is this just a niche issue? Is this just something that happens in a small proportion of people? Well, it's not. And there are a couple of studies out there. I've particularly taken out one Dutch study where it becomes very clear that sexual dysfunction is a mass phenomenon among patients, even though nobody talks about it. And you can see that in this survey, 2/3 of cancer patients said that sex life and intimacy has become worse during their treatment and due to that treatment, or sexual response of the body has changed. More than half say that emotions and feelings towards sex have changed. 24% of women and 14% of men report less desire and think differently about sex. And here we can see a couple of the main reported issues that happen when reporting sexual dysfunction among patients. Erectile problems, fatigue, dry vagina are the most reported ones, but there are many more. And what is also striking is that even though they do not proactively ask for information, because it is that embarrassing topic, more than half say, or around half say in this study, that they do need more concrete and practical information about this topic. So what are the dimensions of cancer-related sexual problems? This was presented at Asco a couple of weeks ago, and I was very, very happy to see this and to bring it into my talk. So I'll be going through these 4 dimensions of cancer-related sexual problems. The first one we should mention is the biological one. And here I have to say, after, having been diagnosed with a stage 4 Hodgkin lymphoma 10, 11 years ago, the regimen I received, some of you might know, is one of the hardest that we had for that disease back then. So, as expected, the biological impact on my body was very heavy during treatment, but also late-stage side effects, which I still suffer now, are very, very present every day of my life. So some of these biological factors are hormonal alterations, pain or discomfort, fatigue, libido decrease. Here I've mixed those that you have present during treatment and those that you experience over time after treatment. Vaginal dryness, weakened or no orgasm, changes in sexual sensitivity, erectile disorder, incontinence during sex, feeling sick, and problems with your nerves or blood vessels in the pelvic area. There's plenty of more, but these are the most important ones that I could find. Then you have psychological factors, very important. We've seen before that there was a difference between women and men in the body image changes. I found that quite interesting. But apparently this is one of the main factors in the psychological one: fear, depression, stress, anger, anxiety, and lack of motivation. Then you have a dimension on interpersonal problems of a patient in partnership. And here you see issues like discord between partners in a relationship, fear of intimacy after going through treatment, maybe after a long period without sex, starting intimacy again might create fear. Also, for those who do not have a partner during that treatment and then want to find one or do find one afterwards, this is an issue. And also lack of communication between not only with the doctor, but within a partnership. And this is not only something that affects the patient. This is not just a dimension of cancer-related sexual problems of the patient. It is also for the relationship as a separate unit, and for the partner. Because often what happens is that the perception of the patient or your partner who's become a patient changes. And this is not only a problem from the patient himself, but the perception that the partner has of the patient. And again, to come back to my example, I do not want to talk about me all the time, but I can say that my marriage broke because of this topic. So it is something that, you know, affects not being able to communicate or what the other person expects from you. It's not always a biological thing. It is very often something that happens between people that are unable to communicate on one line anymore. Then you have a dimension related to social problems. And that is there's also this impact of the societal beliefs, and a very good example of this is reproductive health, where what society expects from you is something very different from what the patient actually wants or needs. Society often dictates what is acceptable for cancer patients and what is not. And on this topic, I presented last year in an educational session here at EHA around fertility. So if you're interested, I would recommend you to go and check that out. And so after all of what I've said already, there is probably no doubt among you that this is an important topic. But it is also important to say that improving sexuality and body image does have, or it's suggested that has a positive impact on the quality of life of patients. There are a couple of studies around this. I've mentioned this one, which was sent to me by a colleague. But there are plenty of them that suggest that this is an important issue to address. But embarrassing stuff is often not discussed. And after, you know, what we've been speaking about here, I think it is clear that there is a lot that needs to be done. And this is something we should be addressing. So what do patients expect from their clinician? So before starting treatment, it is important to inform the patient about the potential side effects during and after treatment. Very often, what I talked about before around the promise to gain normality afterwards is not very helpful in managing expectations and leads to anxiety and depression. It is important that the patient knows what the different options are in treatment and what the consequences of that treatment might be. Important to discuss sexuality during and after treatment and at every checkup, because it's not only important during treatment, it's also important to check what your intimacy and sexual relations are after finishing treatment, being in remission, and also to see what the late side effects might be. When discussing sexuality concerns after treatment, it's very important to be direct, to manage expectations, as I said, ask open-ended questions and not make assumptions. It happens so often that assumptions are being made around age, around people having or not having certain preferences or habits. It's important not to make those. Accept patients' preferences, even if these are not aligned with your plans, even if they're not aligned with your treatment plans. Have additional sources of information and treatment ready. There are a lot, I'll be mentioning them afterwards. Be aware and keep in mind that patient organizations can help you with that task. In my organization, which is a multiple myeloma, as you might know, is a disease where usually elderly people have this disease. It's not a topic we're addressing, but again, that is an assumption again that we're making within our community, that older people do not have sex.
1 minute.
So?
Less than 1 minute.
Less than 1 minute. Okay, so importantly, Asco Guidelines, please have a look at these. There is a list of common health symptoms, possible interventions that might be useful for the patient, and the best moment in time to address these. So my conclusions for this talk are that sexual dysfunction is not a niche phenomenon, but just a major taboo heavily affecting large proportions of cancer patients. A few patients talk about this with their doctor, despite the potential benefits of doing so. Few doctors address the topic, while potential interventions may have a large effect on quality of life of cancer patients during but also after treatment. It's important that you address the topic with your patients, and if you can't, please, or if you're too embarrassed, please do refer them to a specialist if necessary. Thank you very much.